Hello, welcome to Pathagonia. Today we are going to talk about sinonasal and nasopharyngeal lesions. Before we begin, I'd highly recommend you check out Kurt's Notes websites to get a PDF of all of his excellent notes. Without further ado, let's talk about normal first. So in here is a picture of a turbinate, both higher power and lower power. Of note, you see this thick-walled blood vessels? Well, you can get numerous of these, and that's normal. However, if you're not aware of this, these can be thus mistaken for vascular lesions. You can have minor salivary glands arranged in lobules, and surrounding that in the stroma, you can have scattered chronic inflammatory cells, lymphocytes, plasma cells, respiratory epithelium with goblet cells intermixed with squamous epithelium. Now, let's talk about inflammatory. Rhinosinusitis. In adults, allergies are the most common cause of rhinosinusitis. In kids, it's viral upper respiratory infections. Histologically, you'll see a submucosal chronic inflammatory infiltrate composed of lymphocytes, plasma cells, macrophages, and eosinophils. And additionally, as you can see here, you have this thickened, hyalinized basement membrane. And stroma edema, if it's present and prominent, it can develop into inflammatory polyps, which will be covered later. Allergic sinusitis, this is due to exposure to allergen like pollen, dander, and this leads to IgE-mediated reaction. Eosinophils predominate histologically. You can see Charcot-Leyden crystals, and if it's lots of eosinophils, you want to stain for fungus, like a GMS stain, to evaluate for allergic fungal sinusitis. Bacterial sinusitis, you'll have mucopurulent discharge, headache, fever, and neutrophils predominate. Granulomatosis with polyangiitis, as known as Wegener's granulomatosis, this is a vasculitis with necrotizing granulomatous inflammation. It commonly impacts the lung, nasal cavity, and kidney. In the lung and head, you can see granulomas with geographic central necrosis and associated vasculitis, and that can form ulcers and nodules. And in kidney, you can see crescentic glomerulonephritis. This is board fodder, but know that it's PR3 ANCA positive. Let's talk about fungal infections. There's Aspergillus, which has 3 forms of infection. These have thin 2 to 5 micrometers, and just for reference, a red blood cell is 7 micrometers. Hyphae with acute angles, 45 degrees, branching and septation. You can have allergic fungal sinusitis. This is non-invasive fungus causing an allergic response with inspissated mucus, abundant eosinophils, Charcot-Leyden crystals, and debris. Fungi may be scant, and consider getting a GMS if there are a lot of eosinophils. Aspergillus mycetoma, or fungus ball. This is an indolent mass-forming ball of fungus, and you can see here this 45-degree acute angle. Invasive fungal sinusitis. This is destructive invasion with necrosis. You'll have angio invasion, often immunocompromised folks, and require surgical debridement. Mucormycosis. This is zygomycetes fungus that classically infects those with diabetic ketoacidosis and or immunocompromised. It's rapidly progressive invasive infection with necrosis that often requires urgent surgical debridement. They're large and broad in diameter, 10 to 20 microns, ribbon-like, non-septated hyphae with branching at haphazard angles. And you can see well on H&E, and it's highlighted by PAS GMS, but special stains often unnecessary. Dr. Schaber provides this ribbon look to illustrate how it has this kind of ribbon-like growth. Rhinosporidiosis. These are polypoid masses caused by the sporulating organism Rhinosporidium seaburi. It's rare in the US, but more common in India and Brazil. Cysts sporangia, ranging in size from 10 to 300 microns in diameter, containing innumerable sporangiospores or endospores seen on H&E. Mucocele. This is sinus outlet obstruction leading to buildup of mucus. This fills and distends the sinus walls, and it's a clinical radiographic diagnosis. The histologic findings are nonspecific. You have flattened epithelium and squamous metaplasia, inflammation, bone remodeling, and other reactive changes. Necrotizing sialometaplasia. This is squamous metaplasia of your minor salivary glands, just a fancy name. It's a classic mimic of squamous cell carcinoma as it goes deep into the connective tissue. However, the lobular architecture is maintained. You have smooth, rounded contours, not angulated or jagged nests. It's often associated with inflammation and reactive change, as you can see here and as well as here. And you can have acinar coagulative necrosis. Squamous cell carcinoma does not have lobular architecture. It has infiltrative, irregular contours and is more atypical and less inflamed. Benign tumors, sinonasal papilloma, aka your Schneiderian papilloma. There are three types: exophytic, inverted, oncocytic. Exophytic will have exophytic and papillary growth and immature squamous epithelium. The location is the nasal septum. The risk of transformation is very low risk, and molecularly you'll have low risk HPV subtypes. Inverted. This is inverted ribbon-like endophytic non-destructive growth. You have immature squamous epithelium, transmigrating intraepithelial neutrophilic inflammation. The location here is the lateral wall and sinuses. This is low to intermediate risk, and molecularly you'll have EGFR mutations or low risk HPV subtypes. So here's an H&E of your inverted sinonasal papilloma. It has that ribbon-like trabecular growth. An oncocytic sinonasal papilloma, you'll have an exophytic and endophytic growth. You have multi-layered oncocytic epithelium, microcysts, and intraepithelial neutrophilic microabscesses, as you can see here. This is seen in the lateral wall and sinuses. It's low to intermediate risk of transformation, and molecularly it has KRAS. Inflammatory polyp. This is a non-neoplastic inflammatory swelling of the sinonasal mucosa, secondary to and overlapping with chronic sinusitis. You have surface ciliated respiratory sinonasal mucosa, possibly with squamous metaplasia, and you may have thickened eosinophilic basement membrane. You have markedly edematous stroma, as you can see here, without a proliferation of seromucinous glands. You can have mixed chronic inflammation, usually lymphocytes, plasma cells, and eosinophils with occasional neutrophils. REA, or respiratory epithelial adenomatoid hamartoma. This is a glandular proliferation arising from the surface epithelium, meaning it's in continuity with the surface. You'll have a pseudostratified ciliated epithelium, and you'll have small to medium-sized glands surrounded by hyalinized stroma with characteristic thickened eosinophilic basement membrane. This exists on a spectrum with seromucinous hamartoma, which has smaller glands. Chondro-osseous respiratory epithelial hamartoma is a subtype with an admixture of cartilaginous and or osseous trabeculae that are intimately associated with the glandular proliferation. Seromucinous hamartoma. This is a monotonous proliferation of small pink tubules with lobular architecture. It resembles microglandular adenosis in the breast. You have absent to rare myoepithelial basal cells. You have a discernible basal lamina, no infiltrative pattern, no papillary architecture or gland fusion, and it can have eosinophilic secretion. It should be able to draw a circle around all of the glands though, and if it's too confluent, consider a low-grade adenocarcinoma. Nasal chondromesenchymal hamartoma. This is a benign mesenchymal sinonasal tract tumor composed of cysts lined by respiratory epithelium associated with nodules of cartilage and invariably myxoid spindle cell stroma. It's associated with Dicer1 mutations, and so associated with Dicer1 syndrome like pleural pulmonary blastoma, usually seen in kids. CNS lesions, heterotopic CNS tissue, aka glial heterotopia. This is a congenital development. It's displacement of neuroglial tissue in extracranial sites without connection to the cranial cavity. You can see astrocytes and neuroglial fibers associated with a fibrous, vascularized connective tissue. Neurons are usually rare to few, and it may resemble plump fibroblasts, and does not really look like normal brain. It will stain with GFAP and S100. Your differential diagnosis is encephalocele, which is herniation of brain outside of cranium, but it's connected to the brain, and it closely resembles your normal brain tissue with neurons and prominent neuropil and you must exclude quote-unquote surgical misadventure. Pituitary adenoma. This is a benign anterior pituitary tumor. Although usually primary to sphenoid bone, it can erode into the nasopharynx or be ectopic. It can result in endocrine disorders such as Cushing's disease or acromegaly. Architecturally, you'll have solid, nested, or trabecular growth of epithelioid cells with round nuclei and speckled chromatin and eosinophilic granular chromatin. It'll be positive for cytokeratins and neuroendocrine markers. You will not have S100 sustentacular cells staining. It can stain with hormone-specific markers like prolactin and can recur. Meningioma. This is a dural-based tumor. Cytologically, you'll have oval nuclei. You can get pseudo-inclusions. It's a syncytial architecture with whorls and psammoma bodies. The most specific IHC at this moment is SSTR2A, but it's also positive for EMA and PR. Adamantinomatous craniopharyngioma. This is an epithelial tumor derived from embryonic remnants of Rathke's pouch. You'll have basal palisading stellate reticulum, the quote wet keratin, and it'll be positive for beta-catenin in the nucleus of the cell. Hairy polyp. This is a polypoid structure with ectodermal outer layer, as we can see on our top left, resembling skin. You'll have keratinizing squamous epithelium with adnexal structures, including hair, covering mesodermal tissue. It's always fibroadipose tissue with bone, cartilage, and/or skeletal muscle. No endodermal tissue should be present. This is a developmental abnormality, mostly diagnosed in kids. Think, looks like skin and dermis, including hair, hairy polyp. A very rare tumor, salivary gland enlarged tumor. It's predominantly in infants. This is a biphasic squamoid epithelial and myoepithelial complex network of tubules and ducts continuous with the surface epithelium, resembling developing salivary gland. The stroma is hypocellular with more cellular stromal nodules in the center of the polyp composed of myoepithelial cells. It'll be positive for cytokeratin and smooth muscle actin. The old name is congenital pleomorphic adenoma of nasopharynx. The most common malignancy in the sinonasal region is squamous cell carcinoma. However, there are a lot of other tumors that can arise, including some unique ones, many of which have relatively small round blue cell morphology. To help with these cases, Dr. Schaber provides the mnemonic Mr. Sleepin. M. Melanoma, mesenchymal chondrosarcoma. R. Rhabdomyosarcoma. S. SNUC, squamous cell carcinoma. SWI, SNF deficient sinonasal carcinoma. Lymphoma. Esthesio or olfactory neuroblastoma. Ewing sarcoma. Pituitary adenoma. Plasmacytoma. Nut carcinoma. Nasopharyngeal carcinoma. Neuroendocrine carcinoma. Squamous cell carcinoma. This, again, is the most common sinonasal malignancy. It can be keratinizing or non-keratinizing. Like elsewhere in the body, squamous cell carcinoma in the sinonasal tract has malignant infiltrative epithelial cells with squamous differentiation. It arises from squamous metaplasia and/or inverted papillomas. It's associated with tobacco and occupational exposure. There is the high-risk HPV subtypes in a subset of tumors. If it's papilloma associated, there are EGFR or KRAS mutations. It will be positive for your cytokeratins, P40, P63, CK56, and 34 beta E12. And it's negative for neuroendocrine markers like INSM1. It's negative for S100, NUT, CD99 with intact INI1 and BRG1. There's a rare emerging subtype, DEC-AFF2 fusion-associated papillary squamous cell carcinoma. The architecture is exophytic and has an inverted pattern. You'll have broad papillary fronds, acantholytic change, cellular monotony, dense neutrophilic infiltrates, and peripheral palisading. It can be deceptively bland. It has prolonged local regional spread, and the molecular, as inferred by the name, is DEC-AFF2 fusion. SNUC, or sinonasal undifferentiated carcinoma. This is poorly differentiated carcinoma without squamous glandular, or neuroendocrine differentiation. Thus, it's a diagnosis of exclusion. It's somewhat monotonous, with oftentimes prominent nucleoli, and usually demographics are older men. It is positive for cytokeratin, but squamous markers are negative. Molecular, it's associated with IDH2 codon R172 mutation. It's an aggressive high-grade malignancy leading to a poor outcome. Nut carcinoma. This is also a highly aggressive malignancy leading to a poor outcome. It's a poorly differentiated carcinoma, often small round blue cells, as you can see here, but classically with abrupt keratinization in a third of cases, as you can see here. This vesicular chromatin with prominent nucleoli. It's often younger patients in the midline, often in the head and neck. Molecularly, you'll see NUT M1 fusion, most often with BRD4. And IHC, it'll be positive for NUT, CK usually, plus or minus PRAME, P63, CD34. You need a positive NUT IHC or molecular to make this diagnosis. This is not just on histology alone. SWI, SNF complex deficient sinonasal carcinoma. This is also a poorly differentiated carcinoma with high NC ratio. It may show basaloid, plasmacytoid, or rhabdoid features, and it's required to show loss of SWI SNF complex subunit. So IHC, you'll have loss of INI1 or BIRG1 protein expression, and molecularly, you'll have inactivation of SMARCB1 or SMARCA4. It's aggressive and leads to poor long-term outcomes. HPV-related multiphenotypic sinonasal carcinoma. This is an HPV-mediated carcinoma with morphologic and immunohistochemical evidence of myoepithelial differentiation, often adenoid cystic-like. It shows associated surface squamous dysplasia. It's positive for HPV, high-risk subtypes, especially type 33. And thus, if you do a P16, it'll be block positive, but you have to do additional, more specific testing. Although typically presenting as an advanced disease, it seems to be indolent. Lymphoepithelial carcinoma / nasopharyngeal carcinoma. This is another undifferentiated carcinoma with prominent non-neoplastic lymphoplasmacytic cell infiltrate, strongly associated with EBV. It's in the sinonasal cavity. It's called a lymphoepithelial carcinoma. If it's in the nasopharynx, it's a nasopharyngeal carcinoma, non-keratinizing squamous cell carcinoma. There are separate keratinizing and basaloid squamous cell carcinomas in the nasopharynx, less related to EBV. Histologically, architecturally, you'll see sheets of malignant cells with vesicular chromatin. You have indistinct cytoplasm and abundant tumor-infiltrating lymphocytes, as Dr. Schaber points out here. It will be positive for cytokeratins, CK56, P40, P63, EBER-ish, and more common in Asian. Teratocarcinosarcoma. This is a malignant tumor with one immature teratoma, with these primitive neuroepithelial elements with a fibrillary matrix and rosettes. 2. Carcinoma. You'll have squamous or glandular, often with a fetal clear cell appearance. And 3. Sarcoma. Usually fibroblastic, but can show heterologous differentiation. Many have SMARCA4 or BIRG1 loss and or nuclear beta-catenin, usually in older men. Neuroendocrine carcinoma. Like poorly differentiated neuroendocrine carcinomas of the lung, can be divided into small cell neuroendocrine carcinoma, large cell neuroendocrine carcinoma, and it has strong staining with a neuroendocrine stain like synaptophysin, chromogranin, INSM1, and often with a perinuclear dot-like keratin expression. Here we can see some abundant mites with apoptotic bodies with high NC ratio cells with molding and fine chromatin. Mucosal melanoma. Epithelioid to spindled cells with pleomorphic nuclei and often prominent nucleoli. It's distinct from cutaneous melanomas biologically, but you have to exclude metastatic melanoma clinically. It has intracytoplasmic melanin, and it's positive for melanoma markers like S100, SOX10, HMB45, melon A, MIT-F, tyrosinase, do many as can be lost. And it has frequent RAS mutations. It has poor prognosis. Staging starts at T3, T4. No need for Clark-Breslow death. Adenocarcinoma. Salivary gland adenocarcinomas are the most common, particularly adenoid cystic. He delves more into that in his salivary gland tumor notes. You have sinonasal adenocarcinomas, intestinal type. It's a causal relationship with wood dust and leather dust, so mostly men. Morphology and IHC identical to colonic adenocarcinoma, CK7 negative, CK20 positive, CDX2 positive, and non-intestinal type, where CK7 is positive, CK20 is negative, CDX2 is negative. And you can have low grade, where you'll have very bland cytologically to the point where you wonder if it is even malignant. And it has excellent prognosis. And high grade, cytologically malignant, it's a diagnosis of exclusion, and you must exclude metastasis, etc. And it has a poor prognosis. Nasopharyngeal papillary adenocarcinoma. This is a low-grade adenocarcinoma of the nasopharynx with complex papillary and glandular growth, with infiltration of the submucosa. It's low-grade cytology, indolent. It's positive for TTF1, cytokeratin, CK7, negative for thyroglobulin, and PAX8. Rhabdomyosarcoma. This is a malignant tumor with skeletal muscle differentiation, and there are several types. IHC positive for MyoD1 and myogenin, which are the most specific. Also, Desmond. You have your embryonal rhabdomyosarcoma. Cytologically, you'll see round or rhabdoid, strap or tadpole-shaped cells that are eosinophilic in a myxoid stroma. And you can see cytoplasmic cross striations like you see with skeletal muscle. Alveolar rhabdomyosarcoma. This is larger, more rounded, architecturally undifferentiated cells with only occasional rhabdomyoblast, often arranged in an alveolar or nested pattern, and distinctively strong and diffuse myogenin positivity. What's very important for boards and for prognosis is this characteristic FOXO1 translocation, which has a worse prognosis. Olfactory neuroblastoma, aka esthesioneuroblastoma. This is a malignant neuroectodermal neoplasm. It's confined to the cribriform plate and surrounding region. Architecturally, you'll have lobulated nests to sheets of cells with speckled chromatin. If you look closer, higher power, there's high NC ratio, where it looks like your small round blue cells with fibrillary cytoplasm, that is neuropil. You can see rosettes and pseudo-rosettes. It'll be diffusely positive for synaptophysin, chromogranin, SSTR2A, and S100 stain in a sustentacular pattern. And cytokeratin is generally negative but can be focally positive. You grade using the high-end system. Ewing sarcoma, aka primitive neuroectodermal tumor, PNET. This is a malignant tumor of neuroectodermal differentiation. It has EWSR1 translocations with FLY1 or ERG, translocation 1122, usually uniform small round blue cells with sheet-like to lobular growth pattern / architecture with variable necrosis. Immunohistochemically, it'll be strong, diffuse, membranous CD99 staining. It's sensitive, but not specific, meaning if it's positive, it's not 100% Ewing's, it could be other entities. But if it's negative, then it's most likely not Ewing sarcoma. Cytoplasmic glycogen stains with PAS. Pitfall alert. There is an adamantinoma-like variant that can show diffuse staining with cytokeratin and P40. Lymphoma. Always consider a hematologic malignancy and throw on heme stain or two, particularly if it's not staining with other stains. Part of your small round blue cell differential is lymphoma. And you can have extranodal NKT cell lymphoma, where it'll be CD3, CD56, EBER positive, and most common in Asians, and plasmacytoma. IHC, it'll be CD138 positive with light chain restriction. Remember, CD138 in itself is not specific enough for plasmacytoma because it can stain epithelial cells such as metastatic carcinoma. So you need that light chain restriction as well. And it may or may not be associated with multiple myeloma. Let's talk about unique low-grade mesenchymal tumors. Note, spindle cell tumors may not be mesenchymal. Consider salivary gland tumors, melanoma, spindle cell squamous cell carcinoma, etc. Your glomangioperycytoma. This is a patternless proliferation of regular syncytial ovoid to spindled myoid type cells within a richly vascularized stroma and ovoid nuclei. It has prominent vascularity with perivascular hyalinization. You can see staghorn vessels, and you can see extravasated erythrocytes, mast cells, and eosinophils. IHC, it'll be SMA positive. It'll have nuclear beta-catenin because it's a CTNNB1 mutation. It'll be negative for STAT6, ruling out solitary fibrous tumor, S100, and cytokeratins. It's relatively indolent with good survival. Biphenotypic sinonasal sarcoma. This is a low-grade spindle cell sarcoma. It's biphenotypic because it has evidence of both neural and muscular differentiation. It's cellular, and in the submucosa, you have the spindle cell proliferation, as we can see here. And it's arranged in intersecting fascicles, often herringbone, as you can see here. And it can infiltrate into the bone often, and it can induce epithelial proliferation. It's biphenotypic. The neural component will be S100, either focal to diffuse positivity, and SOX10 negative, and the muscle will be SMA positive, focal to diffuse. Desmin can be positive, but can also be negative. Molecularly, it has a PAX3 rearrangement, usually with MAML3, and has slow continuous growth recurrence, but no metastasis. Sinonasal tract angiofibroma. This is locally aggressive, variably cellular fibrovascular neoplasm, almost exclusively to young to adolescent boys. Quote, juvenile angiofibroma, and it classically causes epistaxis and obstruction. It's a richly vascular tumor with variably sized blood vessels set in fibrotic stroma. Vessels are usually thin-walled and often dilated with variable smooth muscle. It has nuclear expression of beta-catenin and AR, and you treat with embolization to reduce bleeding and surgery. This is an excellent small round blue cell differential and how you can use your panel of immunohistochemistry markers to differentiate your various small round blue cell differentials in the sinonasal tract. So I'll leave this here for your review. But just note that weak staining with synaptophysin, CD56, and cytokeratin can be seen with many tumors and should be taken in context. Look for strong diffuse staining, like lighting up a Christmas tree. I'll leave this excellent algorithm that Dr. Schaber provides for nasal small round blue cell tumors. But your starting IHC panel, you want to order AE1, AE3 pancytokeratin, P40, synaptophysin, SOX10, CD45, CD99, and desmin. And just some tips: start with the whole panel and then work through the algorithm and get additional stains studies if necessary. And potential pitfalls: many non-neuroendocrine tumors can show some staining with synaptophysin, like rhabdomyosarcoma, and many of these lesions can stain with PRAME. Well, thank you so much for listening and watching. We hope you enjoyed this episode, and we'll see you next time.